Welcome back, everyone, to Lessons Learned from the COVID-19 Pandemic, Redesigning Clinical Care, Research, and Public Health. I hope you were able to join us for the first session of this conference that was called What Went Wrong and What Went Right. And now I'll be joining you to chair the second and last session of today, Wednesday, September 27th, called The Health Systems Fights Back. My name is Jeffrey Lazarus. I'm a professor at the City University of New York, graduate program on public health and health policy, and a research professor at the Barcelona Institute for Global Health. Joining me will be two speakers for this session, and then we will have an interactive panel with the speakers, with my co-directors who are live in the studio in Utrecht, and your ability to send questions into the chat that we can then discuss as a group. Our first speaker is Agnes Succat. Dr. Succat is from the Health and Social Protection at the French Development Agency, France. The title of her talk is The Resilience of Health Systems, an example from the global North. Welcome, and over to you.
Thank you very much. So what have we learned in terms of resilience of health systems during the COVID-19 pandemic? In many ways, COVID-19 has been an extraordinary natural experiment, with all countries facing the same threat at the same time. Response was society and region dependent. The crisis was therefore likely a preview of future environment-related crises, whether from climate change, biodiversity loss, pollutions, or AMR. This is what we have started learning, and we will have to take the lessons learned on board. This crisis tested, in many ways, the 20th century health systems that we have inherited, and the early 21st century global architecture we built over the past 20 years. So the health systems as we know them today, they took the COVID test. Question is, did they pass it? And in order to start addressing this question, I think we can use the health system framework that everybody is familiar with, looking at 6 dimensions of health systems, 6 pillars or areas that we can try to learn from on how they did during the pandemic. Let's start with financing. 3 messages there on the mechanism for response and the mechanism for preparedness. So mechanism for response did work, but mechanism for preparedness did not, is the overall message. One is the counter-cyclical policies and deficit financing worked. There was a massive expansion of social protection during the crisis and massive deficit financing through debt. And the mobilization of global financing, that's message 2, has been overall a success. From all parts of society, including from governments at national level, but also from development banks at global level, multilateral development banks, public development banks did increase massively their credits and their credit lines to countries. And the third message is that the ODA-centered global health architecture, in many ways, did not do well and is not fit for purpose. So a kind of good report card for the financing system and the financial architecture, the global financial architecture, a less good report card for the global health architecture. A few data on that. First, when we look at the difference between 2019 to 2020, and now we do have actual spending for both developed and developing countries, we see that government spending was the main driver of the increase in total health spending between 2019 and 2020. Across countries, government per capita spending on health usually increase It increased in all income groups, and it rose faster than in previous years. It's not completely universal. Some countries had a decrease in health spending that was linked to decline in use of services, but most countries, on average, increased their spending during the 2020 crisis. However, when it comes to the ODA-centered global health architecture, we see that ODA did not really deliver in 2020. In fact, health spending from aid, from ODA, increased only marginally, particularly in low-income countries. Aid has remained stable at about 29% in 2020, the same as 2019, and it just raised marginally a little bit above $10, but basically in the same order of magnitude for low-income countries. And still, in 2020, the response was mostly national, and it was mostly domestic, and it was mostly private spending, which remains the largest source of health spending in low-income countries. As in 2019, for the low-income countries, the poorest countries in the world, external aid remained higher than government spending on health. If we look at what was actually spent at country level, we see that in 2020, spending from external aid remained close to the 2019 level. So that feels counterintuitive because, well, there was massive mobilization of financing from different global mechanisms. However, this was mostly commitment. This funding was not used, and the response in low and middle income countries mainly came through reallocation of public spending from other sectors to health, though less investments in other sectors, including less in education. The crisis came actually on top of a trend of the past 2 decades in which public spending on health in low and low middle income countries has declined. And if you see the 2 lines on the bottom of the graph on the right, you see that decline in public spending in low-income countries and low middle-income countries. That is, overall, at a time where there was increasingly the awareness that global health is indeed one of the major issues that need to be addressed collectively at the time of globalization, in fact, domestic financing in low and low middle income countries was declining, and the public spending on health per capita and as a percentage of GDP in low income countries remains very low. One of the surprising findings, maybe not so surprising for economists who are familiar with the question of fungibility, is that actually there is a role of ODA in actually crowding out public spending, domestic public spending. And what we find at macro level, we knew this was happening in certain countries. In-depth studies in Kenya and Bangladesh had shown that. But we see now that among a large group of low-income and low-middle-income countries, when external aid increased, health priority in domestic budget allocations declined. In fact, low-income countries and low-middle-income countries tend to have difficulties in absorbing additional amounts of financing, but also governments choose, when they have additional resources coming in the form of earmark funding, choose to reallocate their own spending, including reallocating to other sectors. So that brings us to actually, and we have a paper is about to come out soon on this, is a little relationship between ODA per capita and service coverage, even when we use the index for infectious disease. And probably one of the key reasons for that is that crowding out effect of domestic financing. Next is the question of governance. What is the main lessons learned is the need to build stronger institutions, and that was very clear in the previous panel. The first message, the need to step up investments in the commons, in those institutions that need to manage the collective question of population health, of societal health, surveillance, regulation, One Health. The second one was already also discussed in the previous panel, is the question of trade-offs, the need for societal and multisectoral analysis and dialogue, the question of the impact on the economy of lockdowns, the impact of lockdowns in Africa with a very young population who is working mostly in the informal sector has been quite important, and the benefits of the lockdown have often been difficult to assess in relation to the cost of this lockdown on the livelihoods of people. The question of schooling and the impact on schooling outcomes of lockdowns or of schools being offered only remotely has been extensively documented. We don't know what the impact in the long term will be. The third message, which is fundamental to this crisis, is that we need firewalls between science and political institutions. And we've seen that express itself in many different contexts, very different contexts politically. In China, with the zero COVID policy, in the US, with the strong political influence of science institutions, like the Center for Disease Control. And in many, many contexts, we are all familiar, both in low and middle income countries and in OECD countries. We've seen this tension between the scientific debate and the political debates. And we've seen often scientists going into politics as well as politicians going into science. And it's not the probably optimal organization that we would want. So what are those commons that we need to invest in, those institutions? What more than ever the COVID pandemic has shown is that there are aspects of human health that we need to manage collectively. And that requires mechanisms that address market failures. And we need to invest in those institutions that contribute to human health and economic progress over the long term, but through public financing instruments, because the market doesn't deliver. And in many ways, the pandemic, the COVID-19 pandemic has been an artifact of globalization, because all countries have lived through the same experience at the same time. But we see that we have so much in common as a human community that we need to address the failure of this market, and we need to address it by investing in institutions that build the consensus and provide frameworks and action to address these market failures. Market failures, these common global, these common goods and common goods for health are typically either public goods, meaning they are non-rival and non-exclusionary, or they have large social externalities. So 5 categories of common goods for health, and the Financing Common Goods for Health Technical Expert Group identified those in November 2019. Unfortunately, a bit late, but the message has been given many times about the need to invest in public health institutions. Not that much new there. Information collection, analysis, and communication, policy and coordination, regulation and legislation, taxes, fines and subsidies, and population-wide services. Those public health programs that we've been advocating for decades. Next is the question of service delivery. And here I would say the key message is the need to reset. First, the need to reframe the paradigm around hospital investments. For a long time, the public health discourse and the public financing efficiency discourse has blamed hospitals for many things. But in time of crisis, one of the first bottlenecks to addressing the sudden surge in number of patients has been the lack of capacity of hospitals. And we know that over many years, one of the ways to address the growth in health spending has been to apply very strict efficiency measures on hospitals. It's probably time to rethink that and to think about health systems that don't vilify hospitals, but actually work on integrating community health, primary health, and hospitals of the 21st century. Message 2 is we all love PHC, but in many ways, PHC is motherhood and apple pie, and the PHC 1978 brand of the Alma Ata needs a reset. Before the pandemic, we used to say we need to invest in PHC. After the pandemic, we need to say we need to invest in PHC. We need to say more. PHC should not be just a mantra. We need to think about what it means and what kind of health system the 21st century needs. And that brings to message 3 about that kind of system. Clearly, resilience requires multi-sectorality and the inclusion of private sector providers. All the studies on resilient health systems have shown that countries that live through different and recurrent and repeated crises respond to them through including all segments of societies and including private sector providers and private sector actors. That's certainly the case of countries like Lebanon or Jordan that have had, unfortunately, that long history of multiple crises. To illustrate this, let's look at the progress in service coverage over the past 20 years, and that's the UHC, the Universal Health Coverage Service Coverage Index, which has 4 components: maternal and child health, infectious disease, non-communicable disease, and service capacity and access. And then you see over time, what we see statistically is that access to health services has increased over the past 2 decades. And the calculations of the World Health Organization and the World Bank estimate that about half of the world has access to health services. Problem is, as you can see, is that over time, the rate of increase of this coverage has slowed down and is currently plateauing. And one of the concerns that the community working on health system has today is that most of this progress is actually largely a statistical artifact, which is the very quick increase in intake of HIV interventions, which is included in the indicators. But when you look at the sub-index on health system, for example, this sub-index is flat over the past 2 decades. So density of health workers, density of hospital beds has not changed because population has increased and most countries just catch up. That's the case for low and middle income countries. And as you know, both in the former Soviet Union and in many OECD countries, the trend has been in actually reducing hospital beds, which might be a good decision in many cases, but as we have seen during the crisis, might also be questioned in terms of having the kind of flexibility to respond to a surge. So that's of course, you always have this issue of which indicator and how much the indicator captures reality. But what we know is that there's been very little progress in health system investments over the past 2 decades, that we are now plateauing. And this is very much a concern because if half of the world has access to health services, the other half has not. And that's not the easiest half. It's the most difficult half that doesn't have access. It's the poor people, it's the poor countries, it's the poor people in all countries. So in fact, the most recent report, which was launched in New York last week, shows confirms the trend and shows that service coverage is stalling, and catastrophic spending, that is the spending that affects household due to accessing health services through payment, has worsened over the past decade. So we have reached a stage of actually moving backwards in terms of universal health coverage. So that's in green is the trend we would need to reach the SDGs on this graph, while the real trend is the blue trend, in which you see a slight progress going to the right, but definitively a decline going down when it comes to catastrophic expenditures. Reaching the next to last aspects is the human resources. And here, there is definitively a role in the crisis in having highlighted a problem that was there before, but received little attention, which is the global shortage of health workers and the very acute and difficulties that the labor market for health workers is facing. So key messages is that the shortage of health skills affect almost all countries, rich and poor. It is a global problem. It's no longer a problem of poor countries. Rich countries face a shortage, don't produce enough health workers, and that is found in almost all countries. Second, the crisis showed very acutely the role of women in the health workforce and the fragility of the health system that relies on unpaid work or underpaid work and difficult working conditions. And we know the problem that post-crisis we have with attrition of health workers and the question about revisiting the policies that support the both training and remuneration and social assistance for workers, including informal workers in communities. Last message, again, problem of the global health architecture. There's been little investment, almost no investment when it comes to ODA in the health workforce before the pandemic. The global architecture has focused on the availability of medical products, but it has not paid much attention to the workforce. That represents about 70% of the production function of health services when it comes to the cost function of these health services. And when you look at this health system and human resources issues in poor regions like West and Central Africa, which lag behind in terms of indicators, overall health indicators, you will see that, in fact, the health system investments have been almost inexistent during this time, and there's been no improvement in health system indicators in those regions, despite the massive amounts of aid that represent more than the public spending on health of these countries. Finally, when it comes to medical countermeasures, and that's a very powerful message there, is that in many ways money was not the issue. First, there has been a massive mobilization of funds for medical countermeasure. The role of BARDA in the United States has been very much documented, but it's also the massive amounts that countries in the European Union and the European Commission have put on the table. And overall, as I mentioned before, there has been quite a solid reaction from all the financial institutions to mobilize money. There is also the mobilization of funding for ACTA. However, the biggest problem has not been money. The biggest problem has been the major imbalance of power between the states and the pharmaceutical industry. And that has been illustrated most recently when the documents, procurement documents for vaccines of South Africa were made public, in which you see that South Africa did have the money. South Africa sent money to COVAX to purchase vaccines and got only about 20% of what it ordered in terms of quantity. it actually paid for it, and it also paid for purchasing vaccines on the market, but they had very little negotiating power. Money was not enough. What was really key in those documents is to see the governance issues around the conditions of these contracts and the imbalance of power between the powerful global industry and one country having to face that industry. And that leads us to the third message, which is to the need to anchor the financing, the regulation, and the production of medical countermeasure in spaces of sovereignty. And this is the issue, because this is where the difference occurred between India and Africa. It's about the same population. It's around 1 billion people. But India, because it had sovereignty, regulation, and production sovereignty on its soil, was able to impose its conditions. There was a more balanced equilibrium of power between the industry and the government. In Africa, that balance did not exist because there is little production of medical products on the continent, and there is very little regulation, and the power of governments was solely related to money, but the other instruments of power of governments, the other instruments of collective action, such as regulation or control of the production on their soil, on their territory, could not be used. And that's part of what is now the effort that African governments and African institutions are championing, is to address this, and over the next decade and beyond, build a capacity to produce and a capacity to regulate that production of medical products. Last is the data and information systems. Here, a lot of questions about what happened in terms of information, and I think still the lessons need to be brought more in a more stringent way in the global discussion. But let's start with success. COVID in many ways has been an incredible success of horizontal collaboration. Collaboration between academic centers, collaboration between public health networks, collaboration between North and South. The information, the scientific information has circulated very fast, and scientists have been pretty amazing in sharing early and sharing transparently and widely their findings. But at the same time, as a second message, there's been a change in the way this information has been managed. There's certainly been an emergence of regional response, and that's been the role of the Africa CDC in Africa, and the political leadership of African heads of state around the response, which has substituted for a quite weak, globally centralized system. And it was mentioned in the previous panel, the question of airborne transmission, the question of the moratorium on the booster dose, the question of universal vaccination targets. The global messages were often either unclear or controversial. And that's one of the issues that need to be addressed in the future. And that comes back to really this question, this governance question of firewalls between science and politics, and the question of how, for example, at global level, the WHO handles science while it is in its nature a political organization. The third message is really the problem of fragmentation of data system along disease 9. The data system that was built in the global health architecture is very much along disease, which means that when there is a new problem occurring, like COVID-19, in fact, systems are not ready. And as we're facing these growing environmental threats, the question is, how do we integrate data system into a One Health approach, bringing environmental data and animal health data together with human health data. In conclusion, the sort of areas that would need to be quickly addressed is the question of investing in the global commons. How do we invest in networks that bring together the regional institutions that handle surveillance, that handle regulation? The question of incentives for financing preparedness, that comes back to my first message. The financing of the response was a success. The financing of preparedness was a failure. And now the pandemic fund, in many ways, is trying to address that. But there is overall the question of how to provide incentives to all countries to finance preparedness. Third is really this question of sovereignty of regional economic communities on production of medical products. It's not going to happen in one day. We know that the development of an industry in a continent which doesn't have one is going to take years, but that's fundamental to global security. The independent science governance, that question is still pending. For climate, we now have the IPCC. What exists for global health? And there is probably a need for a mechanism similar to the IPCC for global health that provides independent scientific evidence to the global community. And finally, we need a health system reset. The 1978 PHC slogan, the Amartya slogan, will not be enough. We need to rethink health system along what we've learned during the pandemic. Thank you.
Thank you very much. That was an incredible tour de force about the health system's response during the pandemic. And you raised so many issues that we're going to need to do our best to discuss during the panel. You talked about money and the fact that we may have had enough and it wasn't always the issue. You talked about the rehabilitation of the role of hospitals and not always villainizing them as expensive components of the health system. You talked about global commons. You talked about how to separate science from politics. A lot of important issues that we're going to really need to unpack in the panel. But before we move to the panel discussion, I'd like to invite Dr. Sunil Solomon, who's joining us from Baltimore, from Johns Hopkins University in the US, and he'll be talking about the resilience of health systems, whereas previously we just heard from the North, an example here from the Global South. Over to you, Sunil.
Good morning, good afternoon, or good evening, depending on where in the world you're tuning in for this presentation from. I want to start by thanking the organizers for the opportunity to speak here today on the resilience or the lack thereof of health systems, an example from the Global South, specifically India. These are my disclosures. I want to start just by giving a broad overview of what the COVID epidemic in India looked like. We saw our first case in January 2020, and since then we've reported about 45 million cases. As you can see, we had three spikes. We had an initial surge between August through October, then we had the Delta surge, and then we had the Omicron surge, and we really haven't seen any spikes in COVID in India since then. I would also say that, like most of the world, the reported cases these days are probably like a gross underestimate of the actual number of infections, just given the transition to home-based testing and other modalities of testing. So I want to present over the next 15 or 20 minutes on the responses of the health systems to each of these three different waves and what we should be doing to prepare ourselves for future pandemics. So let's start with the first wave. So as I mentioned, the first case of COVID was reported in India on 30th January 2020, followed by the first death from COVID on 12th March 2020. So India instituted a nationwide lockdown, which was like a pretty severe lockdown. Movement was restricted other than for essential services. All transport, rail, bus, train, airlines were all suspended. Schools were closed, colleges were closed, all restaurants, bars were closed. Gymnasiums were closed, industries were closed. So it really was a pretty severe lockdown. So this existed for about 2.5 months, followed by like gradual easing of these restrictions. And so we had the first phase, and then we had a second phase, and then we had a third phase. And then by October 2020, things were sort of like back to normal. And what really happened was, you can see like as we started easing up, the number of cases started going up, but it peaked around September 2020, following which we saw a decline in the cases. But there were several things that India did during this first wave of COVID that I think are critical and things that we should consider when preparing for pandemics globally, not just in India. I want to start with diagnosis and testing, because diagnosis really is the key to containing any epidemic or any pandemic. Because if you know people who are infected, you can isolate them, you can treat them, you can cure them, and that way you interrupt the transmission chain. And this is particularly important for diseases that have a lot of asymptomatic infection like COVID. And part of the reason why we did have such a big pandemic from COVID compared to all the earlier SARS epidemics was the large number of asymptomatic cases that had the ability to transmit. So India actually did a rapid scale up of testing. We started with a few centers, but they quickly expanded to the private sector, establishing private sector partnership, public-private partnerships. They used the GeneXpert machine. They had tests that were developed by MyLab, which was an Indian startup. They also rapidly repurposed all the RT-PCR machines that were being used for HIV viral loads and other testing to perform COVID-19 testing. They also partnered with the private sector, and they actually negotiated a price contract so people could go either to the public sector or the private sector and still pay the same amount and get their testing still for free. In addition, they also had like home-based and field-based sample collection. So India didn't just ramp up testing, but they also did a large quality control program of all the different laboratories. So it wasn't just about the quantity, but it was also about the quality of testing, and the scale and the pace at which they did this really was remarkable. We had over 1,000 or 2,000 testing centers instituted by the government by June 2020. And all this was governed by a large integrated data management system that fed into a central database that allowed us for tracking of cases nationally. At that time, there really wasn't much you could do in terms of management for COVID. Supportive care was the only option. And again, I believe public-private partnerships were the key strategy in India. It helped us contain without overburdening our healthcare systems, because we were able to establish these partnerships. So private hospitals, which have a lot more beds than the public hospitals, also opened up their beds to the public sector patients, and there were establishment of standardized protocols across the public sector and the private sector, which were being followed. And as you can see from the figure on the right, our cases peaked at about 100,000 cases, and our deaths peaked at about 1,000 deaths a day, which was still high, but with an overall case fatality about 1%, wasn't as high as what we were seeing in many of the high-income countries. And I think that was partly led to the fact that we thought that this relatively low case fatality, this low burden of infection, was because the population in India was younger than many of the high-income countries, where they were reporting a lot more cases and a lot more mortality. But in my opinion, I think the greatest challenge in the management of COVID during the first wave was misinformation. Social media channels were like the primary mode of communication, and there was a lot of misinformation with respect to hydroxychloroquine and several other untested therapeutic options that were being disseminated, and people were experimenting on themselves, experimenting on their friends, experimenting on their families. I think that is something that is here to stay, and we really need to figure out a strategy to control that. But that was just what did India do to respond to COVID. And I think most of you who've been looking at the literature, I think more than the impact of the direct effect of COVID on mortality, the indirect effect of COVID is far larger. So what did COVID do to impact other conditions? And I think India actually did a phenomenal job of responding to ensure that mortality from other conditions, I'm just going to use HIV as an example, was not impacted because of the lockdown and restrictions brought about due to COVID. So India has about 2.4 million people living with HIV. The primary way prevention services are delivered are through the targeted intervention NGOs, the TI NGOs. And so this really wasn't uninterrupted because it wasn't happening in government facilities. The outreach workers from these NGOs were still able to get in touch with clients and provide services at the field level. Harm reduction services, India had a policy of dispensing one pill a day, one dose a day for medications for opioid use disorder. But during COVID, they switched to weekly dosing, and this actually allowed for people to come to these centers less frequently while still providing them with the essential service required to prevent their risk of acquisition of HIV or hepatitis C. Antiretroviral therapy in India is delivered through about 700 centers in the public sector. About 1.5 million people are on ART, and of these, about 80,000 people are thought to be in the private sector for care. And so what did India actually do to ensure that continuity in antiretroviral therapy? I think the first thing they did was they transitioned to telemedicine whenever possible. I think in India, the standard was to have like in-person state expert panel meetings, but all those in-person meetings switched to e-panels to facilitate continuity in care. They also switched to multi-month dispensation for all people living with HIV. Initially, it was only for people who were stable on antiretroviral therapy, but to ensure that patients or clients didn't have to travel to the antiretroviral therapy centers frequently, they dispensed multiple pills at a time. So this reduced the need for people to travel and expose themselves to COVID. They also made it more flexible. So normally, people who are on antiretroviral therapy can only go to one antiretroviral therapy center in India. But what they did was they said you could go to any of the antiretroviral therapy centers in India, including the private sector, and avail care free of charge. And the last thing they did was home delivery. I think some things we don't think about is like in many settings, human resources tend to be underutilized. So we had several outreach workers who were not able to provide outreach because of the restrictions. And I think we really have to be creative in certain situations. So instead of having like 20 or 30 PLHIV coming to an antiretroviral therapy center every day, we were able to get one outreach worker to deliver medications to each of these 20 people at the field level. And it was either home delivery or field-based delivery. And in that 6-month period between April and October 2020, we delivered about 18,000 courses of antiretroviral therapy to people at the field. And I think this is something that we need to think about as we move forward is if people can't come to the center, what are the different options? Can we use courier services? Can we use drones like what's being used in Kenya more recently to deliver PrEP? And we need to start thinking about creative strategies to ensure continuity of care for services that may be interrupted because of such emergency public health situations. And the last thing I want to talk about is HIV testing. So HIV testing is provided through over 10,000 testing centers across India, but there are also private sector labs. And this was a service that really was impacted. So you can see on this figure, if you look at any of them, prior to the lockdown, we were testing about 3,000. We were eliciting contacts for about 3,200 people, and testing about 858 people, and about 858 people are being newly diagnosed. But during COVID, during that period of intense lockdown, that dropped to 198 people. And this was across 5 districts in India where our program was operating. But this was something that happened across India and in the states that were most severely affected by COVID. Like, for example, in Maharashtra, the number of cases literally dropped down to like single digits. So it really does show that impact of COVID does affect care for other conditions, and it's something we need to think about when we institute lockdowns and other such measures. But this was something that wasn't unique to India. This was global. So looking at these data from South Africa, from 65 primary health centers that were providing HIV testing, you can see that during the phases of intense lockdown, the number of people receiving tests dropped. So we really do need to come up with strategies on how do you ensure continuity for testing services, because most of the time we end up focusing on treatment and we forget about that. To get people on treatment, they need to be diagnosed and linked to care first. But this wasn't just for HIV, but this was for other programs, right? For example, if we're looking at the impact of COVID on hepatitis C, like that WHO has ambitious elimination targets. Just 1 year of delay in the HCV program reduced the number of new diagnoses by close to 1 million people and increased the number of viremic infections by about 650,000. So I think the lesson that we learn from this is when we are thinking about one disease, we need to be also thinking about every other condition that one condition can affect, because we tend to be very disease focused. And it's important for us to step back and look at it more from a larger programmatic effect and see how do we ensure continuity of services for programs that already exist. So if you ask me the key lessons India or we learned from the first wave in terms of resilience to the health systems is public-private partnerships are critical. We also need to leverage technology to the extent possible, and we cannot let the response to one pandemic impact progress that we've made with another. But I think for me personally, the biggest lesson I learned was we need to put people in the center of the response. For example, we were delivering antiretroviral therapy to people who inject drugs, the children living with HIV, and many of these parents, due to those severe lockdowns, had lost their jobs, they didn't have money to pay rent, they had no access to food. And they were asking us, you're giving us medicines, that great, but who's going to give us food? And how is my child going to study because they've switched to online learning and my children don't have computers, right? So I think it's very critical that we need to take a step even further back and look at all these different interventions or all these different restrictions we put into place from the perspective of people, especially the most vulnerable people. So following the first wave, there were a couple of key things that happened in India before the Delta wave. The first was the establishment of INSACOG, which was the Indian SARS-CoV-2 Genomics Consortium. It was established in 2020 by the Ministry of Health and Family Welfare in collaboration with the Department of Biotechnology, the Indian Council for Medical Research, and the Council of Scientific and Industrial Research. So the goal really was to assess sequences of SARS-CoV-2 in Indian patients and correlate this information from whole genome sequences with epidemiological and clinical data to try and get early signals of are things happening, when should we be locking down, and what really is happening with these different sequences in India, and using that to inform the rest of the world, but also taking lessons from what's happening with certain variants in certain parts of the world and tracking the spread of that variant in India. So this was across 58 labs. They have a random sampling, which is from sentinel surveillance sites or from international travelers coming into the country. And they also have a targeted sampling approach from all the severe cases. So they put out like monthly reports and quarter and bi-monthly reports, which show you the transition of the different variants. So by looking at the content of the variants, it gives you a sense of what we could expect based on where these lineages were earlier before they came to us versus if we're seeing something in India that help us inform other countries of what to expect. And I think these kinds of collaborations are very critical in both ongoing pandemics, but also to prevent future pandemics. The other thing, I think one of India's biggest successes was their vaccine response. And it was pretty remarkable. The entire vaccine program in India happened through an app or like a web platform called CoWIN. They had like multiple help desks in multiple settings where people could go and fill out these forms if they didn't have access to a smartphone or computers or they didn't know how to do it. People helped them fill these out. It's a very three-step process. You get onto the app, you fix an appointment, you go there and you get your dose. And India established over 110,000 vaccination centers across the country. And the first dose was sometime in January 2021. And over time, we gave about 2.2 billion doses. We did see a fair amount of people getting the first and second doses, but very few got the booster. And currently, there really isn't much vaccine uptake at all in India. So let's switch and talk about the Delta wave. I think this is what really put India on the map. And what we really learned from the Delta wave was there really is nothing we can do when we are faced with such a surge. It came on really quick. We can go into details of why we saw the surge that happened at this rate. We were seeing at least 4,000 deaths a day. Some people estimate that it could be almost 6 or 7 times higher than that per day. But there was nothing our systems could do. Like even a resilient system like India with the large public-private partnerships, we were overburdened and we were overrun. And so my key takeaway from this is the best way to prevent the best way to treat a delta wave is to prevent another delta wave from happening, which really brings me to the next step of what should we be doing. We did see a surge for the Omicron, but we did not have too many infections. By that point in time, almost 60% or 70% of the population already had received both their doses of vaccines. Uh, Majority of the population had already been exposed, so there's some combination of acquired and vaccine-induced immunity probably protected India from severe infection and mortality during the Omicron surge. So in terms of future pandemics, there are a couple of key things that I think we should do. The first is to establish an extremely strong network of partners with government, academia, industry, NGOs, private sector, and most importantly, communities. Because it is important to get their thoughts on how these different policies and regulations impact day-to-day lives. Because at the end of the day, we should be taking a more holistic approach to health versus a very disease-focused approach to health. We also should be thinking about establishing a cadre of multifunctional workers. Why I say this is because, for example, if someone was going home to do a COVID test, could the same person be trained to complete childhood immunization or check someone's diabetes or deliver someone else's antiretroviral therapy? So making this cadre of people who could do these multiple jobs would minimize contact in terms of public health emergency while delivering a whole plethora of services. We always talk about integrated strategies in physical settings, but what I think we should also be thinking about is like, can we do integrated strategies at the field level through these multifunctional health workers? This is probably going to be the biggest challenge that we face, and I really don't have a good answer to this because it looks like social media science is definitely the way of the future, and I'm really not sure what we can do to regulate it, but we need to seriously think about how do we regulate what is being put out there, because misinformation can be one of the biggest threats to any pandemic. Even the most resilient health system can be taken down by misinformation. And then obviously, I think INSACOG was a good example of what we need to do, but I think we need to be monitoring for threats, but embrace the One Health approach. It's not just humans, but threats can come from animals, from the environment, with the climate change. Climate change can affect the way mosquitoes replicate, can lead to like outbreaks of other epidemics. So it's critical for us to build these multi-sectoral, interdisciplinary collaborations that really monitor environment threats from like all three different aspects: humans, animals, and environment. The best way to contain pandemics, as I've already said, is early warning signals, but this really requires some kind of a central database with data transparency and data sharing, because that really is the way to identify epidemics or pandemics before they get to scale of what COVID-19 happened. And I think we could actually do this. But the question is, who is going to lead it and how do we actually implement it in a way where every country buys on and there is a lot of data transparency. And last, but probably the most important, is people should always be in the center of all our responses. So if we want to prevent future pandemics, or when there is a threat of future pandemics, if we want to make sure our systems are resilient, we need to make sure that we take care of the people whom our systems are designed to serve. I want to end by thanking you all for your attention, and I'm happy to take any questions.
Thank you so much, Sunil. That was brilliant. The world was really looking at the situation in India, such a populous country producing vaccines, what would happen. And your overview really helped us understand both what happened and really what some of the challenges are. And I think, your conclusions around One Health, around multifunctional healthcare providers is what we need to be doing as we think ahead to future pandemics, and really even without a future pandemic, just really how we should be managing health and health systems. I'm going to invite Auna and my co-chairs back to the session so we can discuss some of the questions that have come from the audience, and the audience is welcome to send additional comments and questions into the chat. I don't know if either of you were at the General Assembly meeting at the United Nations last week or aware of any of the discussions around pandemic preparedness, but I mean, we are, that was on the agenda there, and we are in the process of developing a pandemic treaty. So that's one question, comment you can be thinking about. I know, Aunis, you raised the issue of collective responses, of the need to divide science from politics. We also need to be thinking about enforceability, because we did have systems in place. And I think if you asked a lot of people before the pandemic, even experts in the field, a lot of people felt, yeah, we are prepared. And we've had IHR, international health regulations, since 2005. So what happened, and how can we change things? And I would even put out there, what do we do if a forthcoming pandemic treaty has no enforcement mechanisms? So maybe I'll hand that over to both of you to make some initial comments. And then again, I'd welcome my chairs in the studio to also engage.
Would you like?
No, please.
Well, maybe on a first set of reflection, I think on last week's meetings at UNGA, I think that's UNGA is an event in which collective action is expressing itself, for sure. And that's what we probably have as a global community as the closest to what could be a global government. So in many ways, it should be where we have our conversation, and partially this is happening. But what we see today is that the way this global government, quote unquote, is set up and works is imperfect. And I think there was a lot of disappointment about the declaration, the 3 declarations on health, which were the pandemic preparedness, UHC, and tuberculosis. And I will let Michel Kazashkin talk about the preparedness declaration. But having been involved for many years in the UHC movement, and having been in charge of UHC in WHO, I would say what has been most disappointing on the UHC declaration is the fact that it is completely similar to the 2019 one. So you say, we have the biggest pandemic of the past centuries. It kills more than 20 million people. And we say the same thing. And I think that's the most disturbing. The absence of capacity, collective capacity to acknowledge lessons learned and to develop a new corpus of policy. And that brings me back to the first panel today is, I'm not sure we went far enough on the diagnostic and on really being able to acknowledge how our institution, our global institutions really failed. I mean, you mentioned, I think I'm still puzzled about how the airborne nature of COVID was handled. I'm puzzled about the discussions about the booster. I'm puzzled about the single objective on immunization coverage, which is still there, whereas in Africa, we know that the population is very young and most people have been in contact with the virus. So the need for reform is dire, but we know that the political economy and the geopolitics today are not favorable to more collaboration. It was mentioned today, maybe less collaboration even than before. And I think if we want to be optimistic, we should anchor our future action on what has worked. You know, you cannot build on failure, you have to build on success. And there are successes, and I would say the horizontality of the response has been a success. The success of scientific collaboration has been quite incredible. The success of governments bringing money to the table to respond, building social protection and cash transfer mechanism. The success of paradoxically, of educating people about medical science. I don't think people knew much about viruses before the pandemic, and I think most of people in the world have been educated on the question of trade-offs. And then there are particularly important topics, in my mind, is really this question that is incredibly important in the 21st century, which is rethinking the independence of science. And we know we have mechanism in the scientific community. This is what academia is in many ways succeeding in doing, but probably is not going far enough. The question of conflict of interest, the question of publication biases, but we need to reinforce that, and I don't hear that enough in my view. And that's really an important message. But we also need, if we want to separate science from politics, we also need to address those very questions in politics. And there, I would say that the scientific institutions have done much more than the political institutions. And the political institutions still have a lot to do in terms of addressing conflict of interest of politicians vis-à-vis the pharmaceutical industry, vis-à-vis the economic interest, vis-à-vis the political interest. But that needs to be addressed too. I think that's where we really need to work on the spaces of governance. But probably the biggest issue today is really to separate the space of governance of science from the space of governance of politics. It is true at national level. I think it is a success of the response of many countries. I'm thinking Korea, I'm thinking France. In France, we had a scientific committee, and then we had a national security committee. And the scientific committee was recommending measures, and then the Security Council was taking it or not, and it sometimes did not, and because it looked at the trade-offs, and it really focused on keeping the trust of society, the trust of the population, and in many ways succeeded. Of course, it's not perfect, and it's still. There is a lot of room for improvements, but that, I think, has happened in some countries. And we've seen the counterexamples with countries in which this has been completely mixed and got to very confused debate.
You're raising an issue, sure, we want to separate the scientific institutions from the more political institutions, but it's also the policymakers who are decision makers that are funding many of the scientific institutions. So just very briefly, I mean, you mentioned, in France, how thanks to the political will, you were able to have different organizational setups. But are there other examples where the political decision makers have decided to grant that kind of scientific independence that you're calling for?
Well, I would say that certainly that was the case in many African countries. I mean, certainly in South Africa, in which there was a lot of discussions around the science of the COVID-19 pandemic that was quite independent from the political discussion. So it seems to me that it's not related either to geography or even political systems, because we know there were really difficulties in managing that relationship between science and politics, both in China and in the United States, which you could see have very different political systems. Right. So it's really about the building of institutions and enforcing that point. And it doesn't say that politicians should not talk to scientists. Of course they should talk, but they should talk in different spaces.
I understand. So I know we only have a few minutes left, and we're going to need to end on time. I don't know, Michel, if you wanted to make a comment from the pandemic preparedness session at the UNGA.
Well, Jeff, I attended the 2001 session on HIV and in the UN General Assembly, and I can say there was a huge contrast. So this UNGA didn't come out with any commitment except the one decision to meet again in 2 years' time. It took place in a very geopolitically fragmented landscape that we already discussed earlier today, and in a context where the relative role of New York and of Geneva remained unclear. The people in Geneva saying, we want a strong signal from New York and the global community that what we're doing in Geneva, negotiating this treaty, is important. And the New York people said, well, we can't really take decisions because we're waiting for the Geneva negotiations to move. And overall, the impression, and we discussed that in several instances today, is that we really lack a governance mechanism, what Agnès referred to as a global government, and we lack leadership. In HIV, we had Kofi Annan, we had Mandela, remember, and we had the powerful HIV movement that was nascent at this time. We do not have those elements now, and I really fear that we're sliding into a phase of neglect.
Thank you. That's a disappointing assessment, but I appreciate an honest assessment of the current situation. I mean, it's a bit shocking. Everyone in the world has now had a lived experience with the pandemic. You'd think more people would be speaking out, standing up, people who lost family members, people who have suffered from long COVID, and so on. Sunil, just the last question before we close. I mean, you talked about a very practical solution. Maybe you can expand around this concept of the multifunctional health worker. I mean, we've talked about, we know that, and you're a systems researcher as well, so we know there are community health workers. We know that in many countries, people are taking on many functions where there's deficiencies in the numbers of healthcare workers. But what can we really do, on the ground to prepare and have that kind of healthcare worker who can do many different things, and also maybe to be able to handle a surge? Because I don't know if building more hospitals and having more hospital beds will immediately be possible, although it was suggested by our co-panelist.
Thanks, Jeffrey. I think I agree. I think Agnès also made that reference to training the healthcare workforce. And I think that's something we should think about, right? Because we always think of even surveillance. We always think of it as like samples going to a lab and the lab testing the samples, right? But can we actually break it down into questions that these people can ask them when they go out to deliver services? Like we have like the Anganwadi workers in India, we have outreach workers in South Africa who are doing multiple different services. So can we tack on other services to that so they could actually provide information in a real-time basis, right? And then I think we also need to start embracing technology a lot more than what we currently do, because it's here to stay. And I think big data and AI have a lot to do with how we respond. And I agree 100% with what Michelle also said, is the biggest challenge is all these commitments get made, but we don't see any progress. And if you're drawing that comparison to HIV, I think it's the advocacy, right? So we need that to build up and remember how we actually do that. And at the same time, think about what are the different skills, depending on what level of outreach worker or multi-purpose health worker we're talking about. Is it like high school education versus like college education? Each of them can be given different skill sets. And we also learned this the hard way during the pandemic in India, is when we shut things down, you still are paying them, right? So programs are still, like, it's not like you stop paying people and then you restart paying them. You're still paying them, but they're not really able to do their work. So how do we train them in a way that our resources are being used in a way that regardless of what is happening, something is being done to move towards UHC or move towards any of those ambitious elimination targets we have, whether it's HIV or viral hep or pandemics?
Well, thank you. I mean, we know the Sustainable Development Goals is about integrating, and yet, all of us face the same problems. You have money for an HIV project, a viral hepatitis project, whatever it is. You weren't really within the confines of often the contractual relationships allowed to kind of task shift, which would have made so much sense during the pandemic, and left us often with people not able to work and other the places we had major shortages. Well, in this session, titled "The Health System Fights Back," we heard about the need for more hospitals, more beds. We've heard about the need for multifunctional healthcare workers and the need for strong, independent scientific bodies that are respected by our political leaders. I'd like to thank both you, Sunil, you, Agnes, for these really excellent talks. This is going to conclude day one of our conference on the COVID-19 pandemic. I hope you'll join us all tomorrow. We'll start again at 3:15 CEST. So join in from wherever you are. We do have enduring materials, so there'll be a recording of the full program within a few days on the AIM, on the Academic Medical Education website, and where possible, we'll also provide the slides. So thank you to my co-chairs. Thank you again to the speakers. Thank you to everyone who joined us. We do look forward to hearing from you. Fill in the evaluation forms. There'll be a survey circulating. And good night, good morning, wherever you are, and we will see you for more tomorrow. Thank you.